Good afternoon, everybody, and welcome to the Health and Human Services Committee. Before we begin our public hearings, I will have the committee introduce themselves, starting on my right with Representative Graham.
Well, thank you, Mr. Chair. Good afternoon. I'm Representative Annie Graham. I serve the people of North Yarmouth and the majority of Gray, House District 105. And what can I say about the weather? Well, we got about 20 inches where I live. So we're sort of.
My name is Representative Lucian Daigle, and I represent House District 1, and we get about an inch at home in the storm, just in case you were feeling bad about us. And I represent the people of the second most beautiful area of Maine, because I'm going to defer to Representative Javner. Katahdin is more beautiful.
Hello, good afternoon. My name is Flavia De Brito. I represent House District 64, which is part of Waterville and part of Winslow.
Hello, my name is Sam Zager. I represent District 116, which is part of Portland.
Good afternoon. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County and 16 communities in eastern Hancock County as well.
Hi, I'm Michael Lemlin. I represent House District 53, which is Chelsea, Randolph, Pittston, and Dresden.
Hi, I'm Representative Dan Shigori, and I represent people of House District 55, the communities of Hollowell, Manchester, and West Gardner.
Good afternoon. My name is Julie McCabe. I represent District 93, part of Lewiston.
Good afternoon and welcome. I'm Representative Michelle Meyer, serving Southern Maine's District 150, which is all of Elliott, where I live, parts of Kittery and South Berwick, and I'm honored to serve as this committee's House Chair.
And Representative Griffin.
Good afternoon, everyone. My name is Abigail Griffin. I represent House District 34, which is Clumber, Levant, and Cadescade.
And I'm Senator Henry Ingwerson, representing Senate District 32, the city of Biddeford and the towns of Arundel, Dayton, Hollis, and Lyman. Beautiful area of Maine. And I'm pleased to be the Senate Chair of this committee, and I will be presiding over the public hearings held here today. The purpose of these hearings, I also want to introduce our analyst, Anna, and our clerk, Sophie, excuse me.
Sophie.
The purpose of the hearings here today is to invite testimony from members of the public regarding proposed legislation before this committee. Today, the order of the bills we will be hearing, the four bills, we'll start with LD 2105, then 1922, then 2125, and then 2083. The committee will hear testimony from people present and on Zoom who wish to speak for, against, or neither for nor against the bills being heard today. With the leave of the committee chair, members may ask clarifying questions of the person testifying today. The public hearing is just for that. It's for the public. The committee will have time for deliberation and debate at the work sessions that will be scheduled in the next few weeks. We will take testimony from people in the room and on Zoom in the following order: those in support of the bill, those opposed, and those neither for nor against. The committee will give members of the public priority when taking testimony. Only the bill's sponsor and co-sponsors will be recognized before the public. We do run a 3-minute clock here on testimony. You will see the clock on the front of the horseshoe. As you approaching the 3-minute point, please wrap your testimony up. And kindly, if you notice that testimony before you has covered a lot of your points and you have other things you'd like to say in your time period, please do that. If you have prepared testimony, please provide 20 copies to our clerk, and you may leave those copies down here to the left at the end of the horseshoe. Please sign in at the podium, and we thank you for joining us today. Whether you testify or not, you can submit written testimony to the committee. Please be mindful that testimony is public and available to all once presented. This hearing is live streamed, and there is a recording of the meeting. Please silence all electronic devices. If you are on Zoom, please make sure we are able to identify you when we are ready to take testimony from those attending virtually. If you are having any technical difficulties, please call our clerk, Sophie, at 207-287-1317. Some of our committee members serve on other committees, so you may see us come and go. You may also see committee members eating and drinking at the horseshoe. The public is not permitted to eat and drink in the committee room. Having said all that, we'll begin with our first bill today, LD 2105, an act to update Maine's mandated reporting laws, presented by the bill's sponsor, Representative Meyer of Elliott. And welcome to the committee room, Chair Meyer.
Thank you. It's a pleasure to be here. Senator Ingerson, fellow esteemed members of the Joint Standing Committee on Health and Human Services, as you know, I am Representative Michelle Meyer, and I'm honored to serve as House Chair of our committee. I stand before you today to present LD 2105, an act to update Maine's mandated reporting laws. This committee has placed no higher priority than on the health, well-being, and safety of our state's youngest citizens, our children. The well-being of Maine children must be anchored in and surrounded by a strong network of support and systems that children and their families can turn to, that makes families and communities stronger, and that can identify what circumstances may exist in a home that threaten the health and safety of a child and rise to the level of the need for a child welfare agency intervention. National and state survey information reveal that many mandated reporters are making reports due to concerns about liability, assumptions about families, and a lack of understanding about what the child welfare agency can provide, not because they suspect abuse or neglect. In fact, 2024 data shows that 90% of all reports did not result in findings of abuse or neglect. Our current mandated reporting process can be confusing and challenging for both mandated reporters and child welfare staff. Changes in LD 2105 will streamline reporting requirements, increase training, and provide more clarity on who, in what circumstances, and on what timeline reporting is required. This includes removing the specific list of professional types who are mandated, removing the penalty for failure to report, establishing a timeline for reporting, establishing that the person with firsthand information makes the report, shifting responsibility for reporting as appropriate to DA offices, and increasing the frequency of the core training. These recommended changes came about through the work of the Child Safety and Family Wellbeing Plan and a mandated reporting initiative that arose from it. OCFS and the Maine Child Welfare Action Network have been leading that work, supporting engagement and input from mandated reporters, community partners, parents, and child welfare staff. Their work together has developed a shared understanding of the challenges and opportunities to strengthen Maine's systems of mandated reporting and community support for families. Last session, that work led to legislation we passed here in our committee to clarify that poverty is not neglect. This session, their work has yielded the thoughtful changes being proposed in this bill. These changes reflect a robust process to consider data, gather perspectives, and provide feedback to inform the development of this legislation. It reflects the voices and engagement of many interested parties and impacted individuals. It aligns with a national movement to acknowledge the impact of liability and complexity of policy and practice on mandated reporters and the impact of reporting on families. Collectively, these changes would move Maine in the right direction toward improving our state's mandated reporting process for mandated reporters, for the Child Welfare Agency, and for the safety and well-being of Maine children and families. I have participated in a number of stakeholder meetings on various aspects of this legislation. My plan is to continue to consider concerns and recommendations I've heard, as well as those offered here today, and to return with amended language as necessary to ensure this legislation reflects a commitment held by this committee to keeping children safe and to keeping families strong. Changes to Maine's mandated reporting system must ensure that those charged with this critical responsibility are provided with the training, support, and system that works as intended in promoting accurate identification and reporting of suspected abuse and neglect, and to support understanding the difference and how to best support children and their families with challenges when it is not child abuse and neglect. I hope you will join me in supporting this legislation, and thank you.
Thank you, Representative Meyer, for presenting this bill. Do we have any questions? for the representative? Seeing none. Further testimony in support of this legislation?
It's going to be a race to that 3-minute clock, Senator.
Okay. Speak fast.
Senator Ingerson, Representative Meyer, members of the committee. I'm Melissa Hackett, coordinator of the Maine Child Welfare Action Network. Since July 2024, McQuan has been working with OCFS on a mandated reporting and community support for families initiative, developed in response to feedback from community partners that we should strengthen mandated reporting policies in our efforts to keep children safe by keeping families strong. These changes are the result of a multi-year review of how mandated reporting functions, not just in policy, but in practice. Through focus groups and discussions, we brought together child welfare staff, mandated reporters, and parents. More than 900 mandated reporters participated in a statewide survey, and child welfare data was examined to understand patterns in reporting, screening, and family impact. This led to a shared approach to strengthening child safety while streamlining administrative processes. I'd like to walk through the changes. First, the bill clarifies mandated reporting requirements by replacing a long and inconsistent list of professions with a clearer definition of who is required to report. Interested parties raised concerns that the current list creates confusion about who is legally required to report and when. Instead, this bill defines reporters based on the nature of their professional role interacting with children. Evidence suggests that penalties for failure to report lead to defensive overreporting rather than careful assessment of risk. This strains the child welfare system without improving child safety. This bill would remove the civil penalty to align with emphasizing education to support appropriate reporting. The bill also replaces the term immediately with a clearer reporting timeline of within 48 hours. While immediately signals urgency, it has led to inconsistent implementation and interpretation. Establishing a clear standard supports careful decision-making and information gathering with the need for prompt action. Currently, organizations may identify designated agents to submit reports even when they don't have direct knowledge. Child welfare staff have noted this practice can delay screening and response, as they may need to follow up with several people to gather sufficient information. These delays create safety risks for children. The bill proposes that the individual with firsthand knowledge make the report directly. This change clarifies responsibility, reduces lag time, and ensures reports include the most direct and complete information available. Currently, child welfare responds when the person for the child responsible for the child is suspected, while the district attorneys respond when the person alleged is not responsible for the child. Reporters are generally unaware of this distinction, so make any report to child welfare who refer to the DAs. This change simply aligns the statute with what is already common practice. Finally, this bill would increase the frequency of mandated reporter training, recognizing the importance of education for reporters. Research shows regular training improves confidence, which was emphasized by mandated reporters in Maine. Accurate identification and appropriate reporting is complex. It's critical we provide education, respond to challenges, and help mandated reporters.
Ms. Hackett?
Thank you, and I take any questions. I said it was going to be a race. I
I have a
tried.
question for you. My
Yes.
question to you is, would you like to finish your testimony?
Oh, thank you, Senator.
Yeah.
I just want to emphasize that last part, which is that we heard so strongly from mandated reporters that they want more training. Who says they want more training? But they all said that pretty emphatically. And so that last piece, I just really want to underscore. I know we ask a lot of professionals to take a lot of training. This is really important work. We really need people to have the support to accurately identify and make appropriate reports. And taken together, I know I went through those changes quickly. We believe that these changes will clarify responsibility, streamline processes, and strengthen child safety. Thank you.
Thank you so
And I'd
much.
still be happy to take any other questions.
Yes. Senator Moore, you have a question.
Thank you, Melissa. You did good.
I tried.
You're sliding right in there. One of the areas I guess I'm a little, the bill is also eliminating the civil penalty for failure to report. I'm worried about the consequences of that. Yeah, removing that and not
Yes.
having a penalty for not reporting.
I know that it is counterintuitive to what we want to understand. States that have increased their penalties have seen what you've often heard me talk about in this committee, an over-reporting, right? Folks are very concerned already about their liability. Mandated reporters name that this is one of the most contributing factors to their decision-making and making a report. They feel that liability. And so when you add criminal penalty or civil penalty, we don't see better reporting. We see defensive over-reporting. I'm going to cover and protect myself. I'm going to make a report of anything. And that floods the child welfare agency. It creates that needle in a haystack situation that makes it more challenging for child welfare to be really focused on the cases where kids are unsafe.
Makes sense. Thank you.
Yeah.
Representative Graham.
Thank you, Mr. Chair. Thank you, Melissa. So create a scenario that you're worried that there may be abuse, but you can't figure out whether it is. Like, how does an individual reach out to Department of Health and Human Services or any other supportive agents? Just they're just trying to figure it out, right? And so can you help me with that? Because I think it is great that there's better training, but I don't know if I were in this situation and like, is this abuse? Is this not abuse? I don't know. I need to talk to someone to try to figure out, should I report? Can you help me with that?
Yeah, I really appreciate the question, Representative. These changes in statute really align with the broader work that we're doing. And I'm really proud of the work we're doing with OCFS and parents and community partners that includes training, support. We're having lots of good conversations with folks about how do we set up systems of consultation? How do we set up train the trainers? So somebody in your organization is that expert that you can go to and say, help me think through what I'm looking at. Because we have heard again from reporters that even that one-time training is insufficient for them in an ongoing way to feel like they're really carrying a lot of personal and professional responsibility for identifying and making those reports. And so the more we can really create support around folks, the training, supplemental trainings, consultation, more trainers that are in-house that can really be those resident experts to help support mandated reporters in that day-to-day decision-making.
Further questions? Yes, Representative Daigle.
Thank you for this. I was a dentist for 44 years, and I saw a lot of things in the course of my practice that I looked at and say, is this neglect? Is this abuse? And we used to get some training. The problem is that training wasn't specific enough for me to say, yeah, this is conclusively abuse or neglect. So with the training that you're proposing includes specific things for the profession where they would feel comfortable saying yes or no.
Yeah. Thank you for the question, Representative. What I would say is that we're not asking mandated reporters to be sure, and that's important to emphasize. We're asking mandated reporters to consider carefully, do they have reason and cause to suspect abuse or neglect? And then we pass that off to the experts, right, at child welfare to make determinations about how to deal with the disposition of that case. What we do want to do is make sure mandated reporters have the best information and knowledge to make that careful determination. One of the things we are talking about, the core training that we're talking about here really covers all different kinds of mandated reporters. We've already heard from folks that are part of this process that having additional modules for a dentist, for a hospital staff, for a school personnel working on truancy. We've heard specific ways of providing training to different kinds of mandated reporters would be helpful. And so that's something that we're looking at. Once we're done the core training, we're already talking about how we might provide supplemental trainings for different kinds of reporters.
Seeing no further questions, thank you.
Thank you all.
Testimony. Any further testimony in support of this legislation?
Good afternoon, everyone. Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. I'm Eric Waddell, Executive Director of
Excuse me,
Maine
can I
School
interrupt
Management.
you for a second?
Certainly.
I see your testimony is neither for nor against. Is that true?
That's right.
Okay. I would love to take the supportive legislation. If you could
I'm
patiently
sorry.
wait, that would be
Certainly.
great.
That'd
Thanks
be
so
great.
much.
You bet.
Appreciate it.
Good catch.
Further testimony and support.
Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. My name is Mark Moran. I'm a licensed clinical social worker, the former chair of Maine's Child Death and Serious Injury Review Panel, and the social services manager at Northern Light Eastern Maine Medical Center. I've been involved in child welfare work in Maine for the past 25 years. I'm speaking today in support of this bill with important recommendations for your consideration. I'm also speaking today on behalf of both Northern Light Health and Maine Health. We worked collaboratively on the recommendations outlined in this testimony and offer one public document for the record on this bill. Northern Light Health and Maine Health are generally in support of efforts to enhance the functioning of the child welfare system, which includes the roles and responsibilities of mandated reporters. There are some elements of LD 2105 we explicitly support, and there are others with which we have some concern and for which we would recommend some changes. Section 7 of the bill seeks to repeal Title 22, Section 4009, which establishes a penalty for failing to make a mandatory report. While it may sound counterintuitive to be in favor of mandated reporting and opposed to a penalty for failing to report, Section 4009 is ineffectual, and we support its repeal. To the best of my knowledge, 4009 has never been applied and has no enforcement mechanism or pathway. Additionally, in my experience, situations in which mandated reports are not made arise not from ignorance of or willful disregard for the mandate, but rather from failure to recognize the need to report based on the circumstances of the child in question. This is an education issue that is best remedied with ongoing professional education and perhaps more appropriately addressed by licensing boards if necessary. Section 11 of the bill revises the existing statutory language related to required reporting to the district attorney. The proposed revision clarifies what the responsibility is to notify the district attorney that it lies with the department rather than with the reporter. It also assigns a differentiation of maltreatment committed by a person responsible for the child and a person not responsible for the child to the department. This results in a simpler decision-making process for reporters and a single point of entry for child maltreatment reports. We support all such reports being made to the department. The portions of the bill with which we have concern are primarily in Section 11. As proposed, 4011D, paragraph 1, does not adequately restrict mandated reporting responsibilities to adults. This could easily be remedied by starting the paragraph with an adult rather than a person. Paragraph 1 also eliminates a critical element of the existing statute, specifically language restricting the duty to report to times in which the mandated reporter is acting in their professional capacity. The phrase that follows "a person" is "who in the normal course of the person's professional duties interacts with children or with persons responsible for children." That phrase qualifies the word person. It does not establish when the person must report. or is subject to the mandate, and in the absence of such clarity, the proposed language could easily be construed to require such a person to report whether they are acting in their professional capacity or not. This is a substantial difference from existing law and longstanding practice, and we recommend clarifying paragraph 1 to be consistent with current law as it relates to that specific point. The final concern with paragraph 1 is that it seemingly opens the list of mandated reporters to anyone who has professional duties, if those duties involve interacting with children or people responsible for children. This is a very broad group that would include, for example, an Uber driver, a concert venue concessions worker, or a customer service representative of a cellular service provider. Again, this would be a substantial difference from existing law. A different approach to examining the current list of mandated reporters for more targeted potential changes may be more appropriate. Still in section 11, paragraph 1, sections A, B, and C unnecessarily complicate the standards applied to the degree of certainty required to report. Each of sections A, B, and C establishes its own standard, suspects or has reason to believe, has knowledge of or observes, and knows or has reason to believe. While we would certainly expect a mandated reporter to be contemplative about whether a report is warranted or necessary, having 3 different standards unreasonably adds to the cognitive burden of these decisions.
I'm going to ask you to wrap up your testimony.
Yes.
Thank you.
Continuing to comment on section 11, the first block paragraph in section 1 is also a significant change to the current statute with which we have concern. This proposed language states that only the person with firsthand information about the suspected abuse or neglect may make the report. While we certainly see the value of the reporter being the most direct source of information, this is not always feasible, necessary, or optimal, and I'm happy to elaborate on that if it would be helpful. We recommend at a minimum editing the sentence by replacing must with should when possible. Related to this point, we also recommend amending paragraph 1 by changing shall report to the department to shall report or cause a report to be made to the department. If the committee sees fit to not amend this block paragraph as described, then it should address the conflict that will remain between this block paragraph and the designated agent phrase in paragraph 3 by deleting the designated agent phrase. Finally, we recommend adding to the block paragraph the following sentence. Nothing in this section shall be construed to prohibit a person required to report under this section from seeking consultation to determine if a report to the department is required. Thank you for the opportunity to testify today. I welcome any questions and would be happy to join you for the work session if that would be helpful.
Do you have any questions for Mr. Moran? Seeing none. Thank you. Any further testimony in support of this legislation? Under the room, none on Zoom? We do? Okay. Okay, good. No more in support. Those in opposition? Neither for nor against. You may come back up.
Deja vu, right?
Sorry for the enthusiasm. Senator Ingerson, Representative Meyer, and members of the Health and Human Services Committee. I am Eric Waddell, Executive Director of the Maine School Management Association. Prior to that, I was a superintendent of schools for 8 years in Representative Meyer's district. And I think it bears noting that I'm a former patient of Dr. Daigle as well. I'm here to testify on behalf of the legislative committees of the Maine School Boards Association and the Maine School Superintendents Association, neither for nor against LD 2105. Maine's local public school leaders fully appreciate the intent of this bill and its goals to strengthen Maine's mandated reporter laws and to make the process clearer for reporters and child welfare staff. And we applaud Representative Meyer for presenting the bill. Our members agree that reform is sorely needed. LD 2105 boosts training and requires DHHS to report cases to the DA's office. It also expands the definition of a mandated reporter. We believe this is consistent with the existing policies of many schools, policies which already require all employees and volunteers to report suspected abuse and neglect. However, our associations do have questions about the implications of a few provisions of this bill. A section on page 2 of the bill explicitly requires that, quote, a person with firsthand information about the suspected child abuse or neglect must make the report. Our associations understand the goal of such a change to remove gaps and delays in the information gathering process at the school level. School leaders share these goals as well, but this change would require major shifts in educational policies and training. Many schools use a designated agent system and encourage staff to report potential cases of abuse or neglect to a principal or counselor, who then file reports to DHHS and who have experience working with the child welfare system. Would a new teacher, volunteer, or school bus driver have the same knowledge of how to navigate the system? If these decisions were solely left up to the staff member, we worry that some of these gaps would persist because of the inexperience and or lack of knowledge or confidence in the process of filing a report. We also have questions regarding the timeframes of this bill. LD 2105 would require staff to file reports with DHHS at the first reasonable opportunity, but not later than 48 hours. While we understand the need for timely reporting, school leaders express concerns about the feasibility of this provision in certain situations. For example, if a teacher learns of suspected abuse or neglect on a Friday afternoon, they may want to speak with a principal or school counselor before submitting a report. Under this bill, the teacher would be unable to wait until Monday morning and would have to report over the weekend. While we understand the reasoning behind the tighter deadline, we would ask the reporters be given more flexibility in these situations. Superintendents and school board members fully support the need to strengthen Maine's child welfare system, and we would be pleased to continue to work with your committee to identify ways to improve the system. Thank you for your time and consideration, and I'd be happy to answer any questions you may have.
Thank you, Director Waddell. Does anybody have any questions? Seeing none.
Thank you.
Nice seeing you here in your new role, Eric.
I know.
Further testimony, neither for nor against this bill. Request from the committee for the work session. Seeing none, we'll end that hearing on that bill and we'll move to the next one, which is LD 1922, an act to support workforce development for families that were involved in child protective activities by requiring the sealing of certain records. This is presented by the department bill presented by Representative Meyer. It's not a department bill.
No, it's not a department.
Sorry about that.
Sophie, we're going to need another sign-up sheet here, but don't, yeah. Okay. Esteemed colleagues of the Health and Human Services Committee, as you all know, I am Representative Michelle Meyer, proudly serving District 150 in Southern Maine. I am honored to stand before you today to present LD 1922, an act to support workforce development for families that were involved in child protective activities by requiring the sealing of certain records. This legislation proposes important changes to Maine's child abuse and neglect registry and background check process. These include establishing a clear timeline for excluding unsubstantiated or indicated records for the purposes of background checks, where either no or a low-level finding of abuse or neglect was made, provided no subsequent findings are made within 1 year. Establishing a clear timeline for excluding substantiated records for the purposes of background checks after periods of time where there are no subsequent findings, and excluding the most serious types of abuse: serious physical injuries, fatalities, and sexual abuse or trafficking. The current rules guiding the child abuse and neglect registry and background check processes mean that parents who have had a finding are held back from volunteer and employment opportunities indefinitely. This is regardless of the type of finding. This means that the current process treats a parent who was a victim of domestic violence and, quote, failed to protect their child, the same as someone who seriously physically abused their child. The proposed changes in this legislation create a fair process for ensuring parents' past behaviors don't present barriers to future economic opportunities. In many ways, creating a clear process for the registry and background check process supports incentivizing parents to pursue personal growth, accountability, and rehabilitation efforts, helping individuals rebuild their lives without unnecessary obstacles. Many parents have done the work to rehabilitate and reunify, with a judge determining that they can provide safely for their own children. When those changes have been made and there are no subsequent issues, we should give those parents a second chance to pursue volunteer and employment opportunities. This is particularly important for workforces in fields we struggle to adequately staff, including healthcare, childcare, and peer support, where their lived experience is needed and beneficial. Critical to this proposal is the exclusion of certain types of findings, including serious physical injury or death and sexual abuse or trafficking of a child. This ensures that those who commit the most serious offenses remain on the registry indefinitely. This supports public safety by acknowledging that some offenses present a long-term risk to children, which they should be protected from. This legislation provides an important opportunity to adjust our current policies and practices related to the Child Abuse and Neglect Registry and background check process, to strike a better balance in ensuring public safety, acknowledging that people can and do change, and removing barriers to workforce participation that are important, not just to the economic success of families, but to our state overall. I urge you to join me in supporting this legislation.
Thank you for your testimony, Representative Meyer. Do we have any questions? Seeing none. Further testimony in support of this legislation.
I can sign this a little later.
Hello again. Senator Ingwerson, Representative Meyer, members of the committee, Melissa Hackett, here on behalf of the Maine Child Welfare Action Network. LD 1922 is about strengthening child and family well-being by improving how Maine uses child welfare records, so they protect children effectively while also supporting accountability and family stability over time. Ensuring child safety is not only about identifying and addressing risk in the moment. It's about building systems that reduce the conditions that make harm more likely in the future. Family instability, financial insecurity, social isolation. When systems treat people as permanent risks, regardless of time or context, they undermine those protective factors. This bill grew out of my work with parents with lived experience of Maine's child welfare system. When asked about priorities to improve this system, parents consistently raise the same concern. Maine's Child Abuse and Neglect Registry doesn't distinguish among different types of findings, different levels of harm, or what has happened since. Under current law, all findings remain in the registry forever. There is no distinction between neglect and severe forms of abuse. There is no consideration of whether a child was ever removed from the home, whether safety concerns were resolved, or whether the parent successfully reunified under court supervision. And when a background check is conducted, an employer receives only a flag indicating the presence of a registry finding with no additional information. The result is a system that treats every finding as a permanent universal safety threat. This approach doesn't make kids safer. Instead, it blocks parents from employment and community life that supports protective conditions for families. Our Child Abuse and Neglect Registry should be used as intended, as a tool to keep children safe by focusing on meaningful risks. It should not function as a permanent barrier, excluding families who have addressed concerns demonstrated accountability, and moved forward. This bill takes an evidence-informed approach to the use of the registry. It creates a process that will allow certain findings to be excluded from background checks only after a certain amount of time has passed and only when there are no additional findings. Most importantly, the most serious offenses, as the representative named, sexual abuse, serious physical injury, death of a child, or trafficking, are explicitly excluded from this provision and would always remain visible to background check systems. To be perfectly clear, this bill doesn't change what information the state retains, only what's accessible publicly via background checks. The bill represents thoughtful changes to the registry that strike an important balance to ensuring public safety and providing second chances that support family success. It draws a strong boundary around the most serious offenses, ensuring they're permanently visible in the system, while allowing other circumstances where there is no ongoing risk to child safety to stop functioning as lifelong penalties and barriers to family well-being. I thank you, and I'd take any questions.
Thank you, Melissa. Any questions for Ms. Hackett? Seeing none.
Thank you.
Thanks so much. Further testimony and support.
Senator Ingerson, Representative Meyer, and esteemed members of the committee. My name is Jamie Brooks, and I am here today speaking on behalf of the Center for Parent Leadership and Advocacy in Child Welfare. We are parents with lived experience in Maine's child welfare system and all have reunified with our children. Our cases closed anywhere from a few years ago to more than 20 years ago. In every case, parents did what was asked, made real changes, and were found by a judge to be safe. We are here in strong support of this legislation. Right now, the Child Abuse and Neglect Registry creates lifelong barriers for parents, even long after cases are closed and families are stable. Parents with old findings are blocked from jobs in healthcare, mental health, childcare, elder care, and other helping professions. Some have had job offers rescinded years after their cases ended. Others went to school and training programs to help others, only to learn they would never be allowed to work in their field because of a registry record. And this doesn't just affect parents, it affects children. Many parents can't volunteer on school field trips or help in classrooms. Children notice when their parents can't show up in the same way as other parents. Some parents, even with adult children, are still barred from reading to a grandchild's class. These barriers have a lasting negative impact on family relationships. As a parent, I know how discouraging it is to have your past follow you long after you've done the work, even after demonstrating safety and rebuilding trust. LD 1922 takes a balanced and responsible approach. It does not erase records or remove serious protection. State records remain in place, and the bill includes clear exclusions for the most serious cases. What it does is recognize that people can change and that time and accountability should matter. We respectfully ask you to support this legislation. Thank you for your time and for listening to the voices of parents.
Thank you so much for your testimony. Any questions from Ms. Brooks? Seeing none. Further testimony in support of this legislation.
All right, good afternoon, Senator Ingerson, Representative Meyer, honorable members of the Health and Human Services Committee. My name is Tess Parks. I'm the Policy Director of Maine Recovery Action Project. I am here today testifying in support of LD 1922 on behalf of our statewide team of organizers. We are a listening first organization. Between legislative sessions, we travel statewide to hear from Mainers impacted by our addiction crisis. We also operate the Access Center, a peer-led recovery community center in Augusta, and we have 3 youth caucuses led by young people affected by substance use in Penobscot, Kennebec, and Washington counties. Across our work, we consistently hear that past involvement with Child Protective Services can create lifelong barriers to employment and volunteer opportunities. One clear example of this issue is found in Rider D of some DHHS state of Maine contracts related to background checks. There is a provision that prohibits the provider from hiring or retaining in any capacity any person who may directly provide services to a client who is a minor child if that person has a record of substantiated abuse or neglect of a child. It is our understanding there is neither an appeal process nor any time limit on exclusion. Our executive director, Courtney Gary Allen, a person in long-term recovery, does have a substantiated finding on her record from the period when her children were removed from her custody. Despite dedicating her life to serving Maine's recovery community and repeatedly demonstrating that she is fit to support and supervise young people, she is barred from providing direct services in our Youth Caucus program. Excluding people like Courtney is unnecessary and harmful, as it denies young people access to experienced mentors and meaningful support rooted in lived experience. We need to be clear. Substance use disorder is a chronic but treatable brain disorder. Maine invests significant state, federal, and opioid settlement funds each year into treatment and recovery. Maine's budget and spending shows that recovery is possible, yet our current CPS record system does not reflect that reality.
Tess, could I get you to wrap up your testimony? Please?
Absolutely. So for us, we really see this as an opportunity to provide individuals and families a second chance while also maintaining significant protections for public safety. And I'm happy to answer any questions.
Thank you. Any questions for Ms. Parks? Yes. Representative Daigle.
Thank you for your testimony. I have personal knowledge of an individual who was in an abuse neglect situation. You get incarceration, and then we have a period of about 6, almost 7 years where there's no repeat, and then it falls back into this mess. And the legislation here says that, if you go a period of time, there's no problem. Do we have anything in here for a repeat offender? The second time around, do we give now a third chance? And I know this case very well, and there should never have been a third chance.
That is a question I can't answer, but I'm sure that that's something that could be answered at the work session.
Okay, thank you.
Good question. Any further questions for Ms. Parks? Thank you.
Thank you.
Any further testimony in the room in support of this legislation? We do have a couple people on Zoom. Courtney Mead and Carrie Taylor next after Courtney. Get them up and going here.
Good afternoon, Senator Ingerson, Representative Meyer, and honorable members of the Health and Human Services Committee. Thank you for the opportunity. Oh, sorry, I didn't turn my video on. Thank you for the opportunity to address the committee. My name is Kari Taylor, and I'm here today in support of LD 1922. I'm speaking as a mother and as someone with lived experience. I know what it looks like when a person is in active addiction, and I know what it looks like when that same person enters recovery and becomes unrecognizable from who they used to be. Years ago, I was raising my children while living with untreated substance use disorder. During that period, CPS became involved in my life. I was accused of neglect, which led to my sons being removed from my home. One was 10, the other was 3. I won't go into the details of that experience today, but I can say this clearly. It was the most painful and terrifying time of my life. When my children were removed, I did not immediately enter recovery. I did not suddenly become well. What I learned during that time was how to survive the system. I learned what to say, what to hide, how to look stable on paper. I learned how to get through it. 6 months later, I got my boys back, but my substance use disorder was still there. Punishment and fear do not automatically create recovery. Healing takes time, it takes readiness, it takes support. It takes people who refuse to give up on you even when you're not ready to change yet. Eventually, I did change. I entered recovery years later, and it transformed everything. It changed my parenting, my relationships, and the way I move through the world. Today, I've been in recovery for over 8 years. My sons are now 21 and 27, and I have amazing relationships with them. We are close, we are healthy, we are connected. I'm sharing this because LD 1922 reflects something I know to be true. People can change. A parent's past involvement with CPS, especially when it did not involve violence, should not quietly follow them forever and limit their future. It should not block employment opportunities and stability years after someone has done the work to rebuild their life. This bill matters right now. A CPS record can prevent someone from working with youth, even years later. People with CPS involvement may be barred from roles that include youth engagement. That matters because those are often the roles where lived experience is most valuable. Addiction is already one of the most stigmatized experiences a parent can have. When CPS records function as a permanent scarlet letter, we are not protecting families. We are permanently punishing people for surviving their worst chapter. LD 1922 helps parents move forward. It helps people work. It helps families rebuild, and it recognizes recovery as real. I am here today in front of you as proof that recovery is real and that a person should not be sentenced for life based on a chapter they have outgrown. Thank you for your time. I urge you to support LD 1922.
And thank you for your testimony before us this afternoon. Does anybody have any questions for Ms. Taylor? Seeing none. Thank you. Do we have Courtney Mead? Not seeing Courtney Mead. No further testimony and support in the room. I would ask if there's any opposition to LD 1922 at this time. Any testimony neither for nor against LD 1922? Come on up. I just want to remind the audience that when we have department testimony, they're not bound by a 3-minute clock. Welcome.
Good afternoon, Senator Ingerson, Representative Meyer, and members of the Joint Standing Committee on Health and Human Services. My name is Bobby Johnson, and I serve as the Director of the Office of Child and Family Services in the Maine Department of Health and Human Services. I'm here today to testify neither for nor against LD 1922, an act to support workforce development for families that were involved in child protective activities by requiring the sealing of certain records. LD 1922 would require that OCFS seal, make inaccessible to the public, but retained by the Department for internal use, certain child protective records. Specifically for substantiated investigations, the department would be required to seal the records 3 years after the date the report was received if the child was not removed from the home and the individual has not been indicated or substantiated in those interceding years. If a child is removed from the home, the record must be sealed 3 years from the date the child was removed or 5 years from the date of the report, whichever occurs first, and provided the individual has not been indicated or substantiated in the interceding years. LD 1922 would prohibit the sealing of records in situations involving child fatality, sexual abuse, sex trafficking, or serious physical injury. OCFS strongly supports the intent of this bill, which aligns with our ongoing efforts to update rules regarding the disclosure of substantiated findings in child protective background checks after a period where there is no further child protective services involvement. One of the core tenets of our work is that people can and do change. This is clearly demonstrated in our efforts to support parents in rehabilitation and reunification, which is the goal in nearly all child protective cases. However, we cannot support the bill at this time. First, it is not technically required, as OCFS can achieve this goal through rulemaking. Furthermore, current statute does not speak to the background check process except to provide an exception to the confidentiality of child protective records to allow disclosure of these records for the purpose of conducting a background screening of an individual. OCFS also has concerns regarding the timeframes outlined in LD 1922. While stakeholders generally support allowing individuals with past child protective involvement to clear their names for roles in childcare and residential settings, as well as other employment opportunities, opinions differ on the timeframe and the specific process, specifically whether it should be automatic or based on a request for a review measured against set criteria. While OCFS does not fundamentally oppose an automatic process, the fiscal note for this bill indicates a need for 12 additional staff positions in the background check unit in order to manage the required workload, highlighting significant resource implications. OCFS recognizes the profound impact that findings have on families and is dedicated to finding a pathway to clear background checks for those who have made changes in their life that address past issues related to child safety. We respectfully request that the committee allow the department to proceed with current stakeholder engagement, rulemaking, and strategic initiatives. We remain committed to balancing individual rights with the safety of children in settings such as childcare programs and children's residential care facilities, while creating a feasible process within current resources. Thank you for your time and attention. I would be happy to answer any questions you may have and to make myself available at the work session.
Thank you for your testimony, Director Johnson. Do we have any questions? Yes, Representative Graham.
Thank you, Mr. Chair. Thank you, Bobby. Appreciate your testimony. Is one able to go to the Office of OCFS and ask for an appeal or a hearing for the previous not violations, but part of the being involved with your department? Are they able to go and ask for that, or is that not possible at all at this point in time?
So as part of the investigation and case process, there is an appeal process. Once a situation is in court, that appeal process is different and not available in the same way to families. And once a family has resolved the issues, there currently isn't anything in our rules that addresses that for families. And so we are committed to making those changes and appreciate Representative Meyer bringing forward this bill.
So you would say that your department is looking at a way to make that happen with, aside from this bill?
Correct. We've convened a work group with the Maine Child Welfare Action Network, and this is the topic that we've been working on with parents with lived experience and other stakeholders to try to determine what is the best path forward to be able to do that.
Any further questions? Seeing none. Thank you.
Thank you.
Further testimony, neither for nor against this bill. Seeing none and seeing no online testimony left, request for information for the work session from the committee members. Yes, Representative Brita.
Yes, I would like to know what other states are doing, like Massachusetts, Rhode Island, Connecticut.
Okay. Any other requests? Seeing none. We'll go to the next bill. LD 2125, an act to sustain access to children's residential care services.
Yeah.
Would you want to do yours?
Yeah, what did I do?
You're last, but you two want to switch, or? So we're on 2083. All right, this is 2083. An act to expand access to certified residential medication aid training.
It's the
Presented by the bill.
Representative Meyer Day.
This is, yeah, presented by Representative Meyer.
Okay. Okay, Senator Ingerson, fellow members of the Joint Standing Committee on Health and Human Services, as you know, I am Representative Michelle Meyer. I am here to present LD 2083, an act to expand access to certified residential medication aid training. I sponsored this bill on behalf of the Division of Licensing and Certification within the Maine Department of Health and Human Services. This legislation would clarify what types of facilities and/or agencies may use certified residential medication aid, CRMA, training to allow unlicensed staff to administer medications within a facility. CRMA training is designed for unlicensed workers, and successful completion of the course satisfies departmental training requirements for workers who wish to pass medications in certain assisted housing programs. This bill directs DHHS to issue a certificate to an individual who has successfully completed a department-approved certified residential medication aid course that meets the training requirements in accordance with rules established by the department for certain facilities. Additionally, the bill requires the department to review the course curriculum at least every 5 years and allows the department to establish by rule certification fees and sanction fees for certified residential medication aids and instructors. These changes will help to expand access to CRMA training, increase CRMA capacity, and alleviate some workforce challenges in residential facilities. It will also ensure consistency in medication administration, competency, and instruction. The department will follow my testimony and provide further context regarding the need for this bill. I ask that you hold your questions for the subject matter experts and that you join me in supporting the bill. Thank you.
Thank you, Chair Meyer. And we will call the department up on this one. Come on up, Director Monteo. Yeah.
Good afternoon. Senator Ingerson, Representative Meyer, members of the Joint Standing Committee on Health and Human Services. My name is Bill Monteo. I'm the Director of the Division of Licensing within the Department of Health and Human Services. And I would like to thank Representative Meyer for sponsoring this bill. This bill will establish clear authority for the department to establish rules for the certified medication aid training and testing of unlicensed personnel under Title 32, Section 2102, who administer certain medications in licensed settings. It authorizes the creation of rules for certification for the certification of, creation of rules for certification of course instructors, and clarifies the goal of the course is to ensure safe and competent medication administration. Passage of the bill provides for clear authority to the department to establish rules for the certification, decertification, and competency evaluation of unlicensed individuals who will administer medications in these facilities and the instructors who train and certify them. These rules are important to expand access to CRMA training, increase CRMA capacity, and alleviate some workforce challenges in facilities and agencies, and ensure consistency in medication administration, competency, and instruction. While the department does have facility rules that address medication administration in licensed facilities, it does not have clear authority to certify individuals in administering the medications or the instructors who conduct and provide the training. This bill will establish a regular schedule for reviewing and updating the course curriculum, as well as a process for revising the content of the certification process to address changes in medication needs, administration competencies within these settings. The development of the rules related to CRMA training will allow the department to decertify trainers and/or individual CRMAs when serious instances of incompetence are identified, and will result in improved health and safety for individuals receiving medications administrations in licensed settings. The department does intend to engage with the Board of Nursing as it works to establish these rules and the certification process, and to continually and to ensure continuity with quality clinical services in med administration and the development of a process to address changes in med administration competencies, including nurse delegation in certain special cases for various settings. Finally, the department intends to pursue the utilization of a learning management system, which is how we intend to try and increase access to training through a hybrid type of learning management system. We feel that this will help with improving access. I do want to make clear that passage of the bill will help us in the goal of reducing medication errors, which you've heard me come before you and testify is a significant issue in facilities that do not have nursing services. And also in addressing accountability for those errors and really establishing through the rulemaking process a provision for training, retraining, and re-education in conjunction with the board. I will share with you that we have met with stakeholders and we will continue to meet with stakeholders regarding moving forward with this. And I want to thank you for your time, and I'm happy to answer any questions you may have.
Thank you, Director Mateo. Do we have any questions for the director? Yes. Representative Zager.
Thank you, Mr. Chair. Good to see you, Director Mateo.
Thank you. You as well. I think it's the first time this year.
I'm just trying to understand some of the nuances here. So, a certified residential medication aid is different than a CNA, right?
Correct.
Can you please clarify for those in the room?
A CRMA, as we refer to them, was something that was established many years ago. I believe early 2000s to address the inability of or lack of nurses to administer medications in settings that are non-nursing settings. So we were talking residential care assisted living.
Mm-hmm.
We're also talking some behavioral health residential, home and community support services residential, so multiple settings where there's not a requirement for a nurse to be present 24/7 to administer the meds. So the rules or the process that came about, which was under the authority of the commissioner to establish rules for administration in licensed settings, was a curriculum or a course approved by the department. That we issue the course completion certificate, but we don't certify the individuals. And so this is a 40-hour course that takes somebody who has really no prior training or experience and gives them just the basics of medication administration to try and ensure that residents in these settings can get their meds in a safe setting. It does not currently allow for injectable medications other than like a bee sting, epinephrine bee sting kit, for example, I think is the only one. In some instances, stable diabetics, but not on a sliding scale. So there's very restricted use. This is a substantially reduced course that's woefully outdated. The current course, the textbook went out of print. The exam was compromised. And so we started looking at the curriculum, talking with the Board of Nursing, and this really ties into the Board of Nursing's delegated practice about could we jointly work to address this course that which is as I said, substantially less than other courses as far as time commitment wise, to try and come up with a way to ensure the course is revised to current standards. We're addressing medication administration techniques. And the goal with the Board of Nurses is to really, if passage of their Nurse Delegation Act goes forward, is to really come up with a process where nurses could work in conjunction with physicians to delegate, when appropriate, specialty situations for medications. And the example I will give you is, and this was a real example that came up years ago from Representative Daigle's area, where there was a resident in a residential care facility who was going to be getting a Lovenox injection for a period of 7 to 8 days, which is an anticoagulation medication given subcutaneously after surgery. The physician wanted the facility to administer this in a pre-filled auto-injector device, but currently there's no scope of practice for CRMAs, and they're not allowed to do injectables. There's no ability for the nurses to delegate that. So this resident had to be transported daily to a physician's office to get this injectable medication. And I think it was about a 25-minute trip one way. So the rules that we're looking to do with the Board of Nursing would allow for these types of situations to be reviewed and for the nurse to look at it and determine, if this is an appropriate clinical practice to be training the CRMA to do in this small isolated small isolated situation, excuse me. So currently, we don't have authority, Representative, to actually certify the individuals or decertify the individuals.
Who does have that authority?
It doesn't exist. So it's actually
The certified residential medication aid, somebody's
that's the course
certified.
title. And they're taking a program that's a department approved program, and it's the instructors who are essentially passing them and testing them and certifying them, and we are issuing a course completion certificate. But one of the reasons we brought this forward was in discussing this with our AAG and looking at the medication errors that we're having is we don't have the authority to address instructors. If instructors not providing the curriculum as designed, or to address the decertification of a CRMA other than if they don't pass their course renewal, which is done on a 2-year cycle. So there's no current ability now if a CRMA creates egregious medication errors and a facility terminates that CRMA, there's no standard to decertify them so they could move on to another facility, and there's no ability to address or require re-education or training. So what we have is a course that is approved by the department and no actual standards or requirements because we lack clear authority to certify, decertify instructors or trainers.
Okay,
Which
so
is why we brought this forward.
if I may, Mr. Chair.
Yes, go ahead.
So if I understand correctly, a couple decades ago, the position, the role was defined, but nobody was authorized to certify the certified residential medication aid. And this bill would correct for that so that we can have a process to certify and to, in the rare but important circumstances where there's a serious problem, could decertify somebody.
Yes, this bill would give us clear authority. So right now we have the authority, we have a course that is approved by the Commissioner for Med Administration and Facilities. That authority exists in statute. When that authority has been read, it is not clear that that gives us authority to regulate the individual or the instructors.
Okay.
And so that's what we're doing. We're requesting here is authority to draft rules for the instructors and for the actual certification, recertification, decertification process, and the ability to charge a minimal fee instead of using general fund dollars to create or expand a learning management system and maintain a curriculum writer, developer to revise the course so that it doesn't go 15 plus years without being revised, and to work with the Board of Nursing on some of these things that really make sense given today's environment. And as we're seeing increased acuity in some of these facilities, to have a process to address a need for something that's not a standard medication or a standard administration process, if it's clinically appropriate based on the nurse's judgment and the physician's.
All right. Appreciate your answering the questions. Very
Yeah,
helpful.
it's a bit of a complex situation.
Well, thank you for your work.
Oh, I have a question for you. Have you seen an amendment suggested for this bill?
We have seen a proposed amendment. We disagree with the proposed amendment.
That's what I was going to ask you to comment. Is that your only comment?
That's my comment, sir.
Okay, okay. Any other questions?
We're still willing to work with parties.
Okay. So the door's closing, but it hasn't shut. I'm just kidding. Okay.
Thank you.
Yes, any further testimony in support of this bill? Any testimony in opposition? And testimony neither for nor against?
Good afternoon.
Good afternoon.
Good afternoon, Senator Ingerson, Chair Meyer, and esteemed members of the HHS Committee. My name is Angela Westhoff, and I serve as the President and CEO of the Maine Healthcare Association. We represent approximately 200 long-term care facilities throughout the state of Maine. First, I want to offer my sincere condolences on the loss of Representative Kathy Javner. She was a tremendous advocate, a wonderful person, and I know she's greatly missed. I stand before you today to deliver testimony on LD 2083 and offer an amendment that you'll find attached to my testimony. We have officially taken the position of neither for nor against for a very simple reason. The bill as drafted is not clear. I'm trying my best to negotiate a reasonable, collaborative solution, but I'm leaning now towards opposing the bill as drafted. After receiving a lot of calls and emails from our members, I reached out to the department for more information, and they were very gracious in meeting with us to answer our questions. We had meaningful discussions, and there were many points of agreement. Unfortunately, however, the bill title does not clearly articulate the department's intent, as was described to me on 2 occasions. Respectfully, I submit the amendment to you today, and we have already shared it with the department. I have a few explanations, and I might beg the committee's indulgence on the clock, as the department had unlimited time to present the bill, and I'd like to walk through the amendments and the reasoning behind them. We propose changing the title first to an act to establish standards for certified residential medication aid curriculum and training. What's the rationale for that? The original title suggests that the bill will increase or otherwise expand access to the number of people becoming CRMAs. In reality, the intent of the bill, as described to me by the department, is to tighten up the curriculum, to revise it, to tighten up oversight, not to actually increase the number of people who have access to and complete a CRMA training program. MHCA is concerned that the passage of this bill will have the opposite of effect and potentially decrease the number of CRMAs, as the bill is written, charges fees for individuals to obtain their certification when before either they or their employer were only paying for the training. This bill will also create a process to certify, decertify, and sanction RN instructors with fees. Nurses are already in short supply and are often working long hours. I spoke to several RNs who provide this education in a residential care facility that they work at, in addition to their regular clinical role. Respectfully, it is not clear how the new training process for CRMA instructors would be developed. It also isn't clear how the Division of Licensing and Certification has the authority to impose financial penalties or sanctions on RNs. Wouldn't that be the Board of Nursing's role? And I'd also caution us here. Even if the department develops an online curriculum through a learning management system, and it sounds like they're already underway with that, we would still need RNs to be able to conduct the med passes in person to make sure that CRMAs are passing medication appropriately. This could have a real chilling effect if we're going to be threatening RNs with fines or punishment. We are also recommending striking and replacing the language in Section 2. Our new proposed language, we think, explicitly states the intent of the department's bill in a clear manner and uses the department's words that were shared with us last week. It would establish rulemaking authority, which seems to be the main intent. It would provide specific language that the department uses as the basis for standardizing the curriculum and would allow them to charge fees. And the third and final point I would add, and I know I'm out of time, is that it would establish a short-term stakeholder group prior to rulemaking to ensure that the department has direct information from the body of impacted stakeholders. There's a long-standing tradition of doing that, both in this committee and the legislature. When you create rules that impact a broad swath of providers, you seek information from those providers and how they're going to be impacted. Our goal is to improve the bill to better align with stated intent. We offered this amendment in good faith and in an effort to collaboratively make good and transparent public policy. Thank you, and I'm happy to answer any questions.
Thank you for your testimony. Do you have any questions from Ms. Westhoff? Seeing none.
Thank you
so much. Any further testimony, neither for nor against this bill? Seeing no testimony online for this one, I would have us move to the next bill in a hearing, and that would be bill to an act to sustain access to children's residential care services presented by the bill's sponsor, Representative McCabe.
Good afternoon, Senator Ingerson, Representative Meyer, and my esteemed colleagues on the Health and Human Services Committee. My name is Julie McCabe, and I'm honored to represent District 93, which includes a part of Lewiston. I stand before you today in support of LD 2125, an act to sustain access to children's residential care services. This bill would establish an emergency rate increase and a stabilization fund for children's residential care facilities, which provide life-saving mental and behavioral health care for Maine teenagers, and too many of which are on the brink of closing. Though I know you've heard this information before, it bears repeating. Over the past 2 decades, countless providers, and with them hundreds of children's residential beds, have shuttered due to financial challenges. In the past year alone, 100 beds were closed, and just last April, 33 additional beds were taken offline. What remains for Maine teens are 130 licensed beds in the entire state. And what these numbers mean is that kids in likely all of our districts free without access to the level of care they need and deserve. Without the correct level of care, kids experiencing severe crisis too often find themselves in emergency department rooms. I walked through the emergency department floor at Central Maine Medical Center over the summer and saw for myself where kids are forced to spend days, weeks, and even months. It is nothing short of heartbreaking to think of a child, through no fault of their own, in a windowless room for 24 hours a day, 7 days a week. The isolation and sterile quality of that 8x8 room, compounded by the stress of the medical emergencies just outside your door, creates a recipe for disaster, further decline, and is frankly inhumane. Because of the lack of available beds in Maine, we have a situation where children with complex behavioral and mental health needs are forced to seek care out of state. Currently, 67 Maine children live in 7 other states across the country, as far away as Florida and Missouri. And for the nearly 500-day average stay away from their community and home, we have no idea how often children and their families are visiting with each other. But we do know this kind of separation is never good for children and must be a very heavy burden for parents to bear. Further, for many of the Mainers who are able to receive this critical health care, only 23% receive care in their home county, meaning teens from Aroostook County may receive treatment down in Lewiston, where a 2-hour home visit becomes an 8-hour road trip on 95. And that's if staff are available, if weather conditions are favorable, if everything goes right. So unfortunately, like so many of our healthcare services in Maine, kids from rural parts of our state find services furthest from reach. Finally, there are 76 children on the wait list for children's residential care facility services. Combined with the 67 residing out of state, we would need to double the current number of beds available in Maine to truly address this issue. I am grateful for the meetings I've had with the department so far, and more so for the recent decision to include children's residential care facilities in their revised list for 2026 rate increases. However, I still feel strongly that the legislature should invest in the stabilization fund included in this bill, because without that funding source, it is likely we will continue to see providers close while the rate review process takes place. And in that time, more Maine children could go without services, left to contend with acute behavioral health needs on their own. I thank you for your time and consideration, and I would be happy to answer any questions you may have.
Thank you for bringing this bill before us today, Representative McCabe. Do we have any questions for the representative? Seeing none, thanks. Testimony in support of this legislation.
Good afternoon, Senator Ingerson, Representative Meyer, and honorable members on the Committee on Health and Human Services. My name is Adam Bloom-Pykopoulos. I'm the Executive Director of the Alliance for Addiction and Mental Health Services. On behalf of the Alliance, I'm here today to speak in strong support of LD 2125 and to thank Representative McCabe for bringing this important legislation forward today. LD 2125 makes two important steps to address the ongoing crisis in Maine's children residential treatment system that has resulted in Maine children being sent out of state for treatment or being boarded in emergency departments due to the strained and declining capacity of in-state providers. This bill would require the department to initiate an emergency rate determination process for this service and would establish a $1 million emergency stabilization fund to prevent additional program closures while we wait on the rate determination to be completed and implemented. Maine's remaining CRCF providers have been increasingly unable to staff programs that can safely accept many Maine youth due to reimbursement rates that do not reflect high staff turnover and the actual costs needed to operate programs. As a result, Maine has lost over 80% of its CRCF capacity over the last 2 decades, with 111 beds and 2 additional programs closing in the past year alone. This has directly translated to over 60 Maine children out of state placements as of April of this past year, which is included in the report that I've included the link for at the end of my testimony. With that said, we are deeply appreciative of the department's recognition of this crisis and its addition of CRCF services to its final 2026 rate determination schedule. We would respectfully ask this committee urge the department to maintain its shared commitment to promoting a full continuum of care by prioritizing the determination and implementation of this rate as soon as possible and in sincere consideration of the specific challenges outlined today in provider testimony. The second portion of this bill establishes a $1 million stabilization fund, which is just as critical to preserving the system. This fund represents a crucial lifeline for remaining providers to access financial support to stay afloat when waiting for the new rate to be determined and implemented. OBH is already a tremendous partner in being responsive to the needs of providers nearing closure to the best of their current ability. This fund would be an additional tool in OBH's toolbox, and we have full faith in their ability to leverage these funds to the maximum potential and intent. I've included in my testimony here some of the specific issues that this fund would be able to help support. But to give you a general idea, I know I don't have a ton of time. Recent data that we've shared with the department, providers have reported turnover rates as high as 79% in their staffing and financial losses totaling over $1 million annually. That is unsustainable, and this is something that the fund would help to, again, shore up those losses while we wait for this rate to stop any additional closures. These two measures, when we move them together, will provide immediate support and long-term sustainability for Maine to finally be able to care for its own children. We have just 6 providers left across the state. And for these reasons, we respectfully ask that children's residential services be recommended as a priority in the department's 2026 rate determination and implementation schedule, and that this committee continues its support on this important issue and votes ought to pass on LD 2125 to establish a stabilization fund for these services so that providers can continue meeting the needs of the children and families that they serve. Thank you for the opportunity to provide testimony this afternoon. I'd be happy to answer any questions either today or before the work session.
Thank you for coming before us. Your testimony, Adam. Have any questions? Yes. Representative Zager.
Thank you, Mr. Chair. You made a comment that there's only 6 providers left statewide. Can
Yes.
you, I think I have a sense of the answer, but can you just, so that we have your testimony, like tell us geographically where they are?
Absolutely. And I can provide this as well in the report
That would be
here. But they're up in Aroostook County. There's one there, Lewiston, down in southern Maine, and then over on the down east portion of the state. But I can provide specifics as well
For the work session. Thank you.
Yep.
Any further questions for Adam? Seeing none, thank you.
Thank you all.
Further testimony in support of this legislation.
Good afternoon. Senator Ingerson, Representative Meyer, and members of the committee. I am Dr. Rosalind Gerwin, and I am on leadership as a child and adolescent psychiatrist for Maine Health. I come to you today to also advocate for this bill and for the needs of our young patients who are so vulnerable in our community. I'd like to begin with some specifics regarding Spring Harbor Hospital
In the past 2 months, they have admitted at least 7 pediatric patients and have had lengths of stay exceeding 120 days, with the current patient at greater than 300 days and still counting with no end in sight.
Wow.
These long stay admissions additionally can account from anywhere from a third to even 50% of the available inpatient census for the community. These include patients who've been determined to be medically stable for discharge far earlier, but are now caught in the middle of families feeling unable to bring them safely home, and all in-state residential agencies stating that with the current funding models, they are unable to adequately staff and therefore accept these patients. 3 patients at present are now stated for out-of-state programs, further disconnecting them from their families, their communities, and typical childhood development. And when they do get stuck, such as one patient who's been there since October 3rd, they further decompensate, miss school, miss peers, and generally feel abandoned. Additionally concerning is the community ripple effect that limited bed availability can have. Inpatient psychiatric treatment, which is where often, I know we've talked about the ER, these patients can get stuck, is meant to treat and stabilize high-risk and acutely ill children and adolescents. But without these beds, these patients are often stuck in places without timely treatment. Even if you are life-flighted to a pediatric intensive care unit or the PICU following a serious suicide attempt, you might be waiting for timely treatment for your life-threatening medical condition. Additionally, there are people that wait in ERs. They wait so long they give up. They go home, they decompensate, and then they become the next pediatric intensive care unit patient. While not a panacea, this bill would provide flexible funding to build staffing models when needed. Providers have repeatedly identified this as a tool towards getting youth closer to leading a safe, healthy, and productive lives. So I ask you to please support this modest but important fund that will provide positive impact for some of our most vulnerable patients. Thank you for this opportunity to testify, and I welcome any questions.
Thank you, Dr. Gerwin, for your testimony. Do we have any questions? Seeing none.
Thank you very much. Have a good day.
Any further testimony in support of LD 2125?
There. Good afternoon.
Afternoon.
Senator Ingerson, Representative Meyer, members of the Health and Human Services Committee. My name is Lisa Harvey McPherson, and I'm here to speak on behalf of Northern Light Health in support of this bill. Northern Light Health participated in the stakeholder group established in 2023, a resolve to establish a stakeholder group to address the problem of long stays for children and adolescents in hospital emergency departments. And then during our group discussions, we provided information about the long length of stay for youth in hospital emergency departments. And as you've heard, long inpatient stays for youth at Northern Light Acadia Hospital, Maine's second pediatric inpatient unit for children with psychiatric needs. And this is all due to the lack of community residential beds. Not all, but significantly. During calendar year 2025, Northern Light Health Hospital emergency departments cared for 153 long-stay behavioral health youth that were medically cleared, but waiting for discharge to behavioral health care and services. In the report you received last January, the stakeholder group recommended the following: strategies to limit the length of stay in hospital emergency departments for children and adolescents who have been medically cleared for discharge include stabilizing and expanding child and youth residential capacity. And the information from our testimony is gleaned from that report. And it states, without the funding to support intensive staffing services, providers are unable to safely accept children and adolescents to meet their needs, which contributes to the long stay in emergency departments. So this bill implements the stakeholder group recommendation by providing funding to establish an emergency fund to stabilize children's residential care facility providers that are in danger of closing And we are in strong support of this funding, and we ask that you support this legislation. And I welcome any questions that you have.
Thank you, Lisa, for your testimony today. Appreciate it. Any questions?
Okay, thank
Yeah,
you.
thank you. Any further testimony and support?
I know I'm not going to get through mine. So I hope you read my entire testimony. Good afternoon, Senator Ingwersen, Representative Meyer, and honorable members of the Health and Human Service Committee. My name is Jill Allen, and I'm the Chief Operating Officer at NFI North. NFI, which stands for North American Family Institute, has been providing services to children who need out-of-home care in Maine since 1992. With a degree in psychology, a master's in mental health counseling, my employment search focused on a place that served children who had acute mental health and behavioral needs. It was in 1992 I discovered NFI North and began my 34 career providing services to the children and families of Maine. When I first began with children in our Lewiston program, I didn't know what residential treatment was about. I didn't know there were children languishing in psychiatric hospitals such as Jackson Brook Institute, now Spring Harbor. I was saddened and appalled at the number of children who stayed in hospital care for much longer than needed due to a lack of placement. These children were not safe to go home, and therefore the gap in service led them to be institutionalized longer than necessary. NFI North was part of the building of the system of care for children who are not ready to go home but should not be in the hospital. From 1992 until 2008, we operated 11 different children's residential programs in the state of Maine with various specialties. In 1998, NFI North responded to the Secure Treatment RFP and were awarded the bid to bring back over 250 youth who were placed out of state due to a lack of services in Maine. These were 3 secure treatment programs, the first of their kind in the state of Maine. These programs served many youth who had lived far away from their families for months and years to get the services they needed. It was a proud day when NFI North brought back the last few kids and could say that all young people were being served in the state of Maine. Sadly, the trend is being recreated as the cycle of care has come full circle, and we are sending more and more children out of state because we no longer have adequate services in place to treat their special needs. I feel like this historical view is important for you to understand, and that NFI North wants to be part of the ending of this cycle while keeping children in our home state close to their families and invested in their child returning home. Due to overall reduction in support for these programs, both systematically and financially, we recently considered eliminating our children's residential services. NFI North has struggled to cover costs due to a number of reasons, including inadequate reimbursement, poorly designed rule changes, and unfunded mandates that negatively impact our ability to support kids. We are here as a last-ditch effort to plead our case and ask you for your support to help us fulfill our mission of supporting the kids in Maine who need our help the most. Am I out of time?
You are. Yes.
Okay. I think, can I just wrap up by saying, I think what's really important is that in November, I wrote to the department and notified them that we were going to be closing at least 2 of our 6 children programs, which would reduce another 16 beds in the state of Maine. I hope you read my entire testimony. We cannot continue to keep our beds open if we don't get help. That's for sure. The department asked us to come and present today and to stay involved in hopes that you will hear our plea that there will be 16 more kids looking for out-of-state placement very shortly.
So you haven't closed those 2 facilities yet?
We have not, but we are prepared to. And as you'll read in the testimony, and I want to be respectful of everyone's time, for us, the biggest issue is that in 2021, the rule changed that we could not bill for any child that was not staying in our facility that night. And they were trying to align the rule with the adult residential programs that if you're, as they say, if your head is not in the bed, you can't bill. Well, for the adult side of things, which we have 3 adult programs in the state of Maine, they cost settle at the end of the year. So it really doesn't matter if they're in the bed or not because they cost settle. For the children's services, there is no cost settlement. And I tell the example in here that we, on many, many occasions, will bring a child because we don't have mobile crisis available to us anymore. We'll bring them to the ER for an assessment, a crisis assessment. We'll wait until wee hours of the morning to get the assessment. They'll release us at 2, 3 o'clock in the morning, and we are not allowed to bill because if the child is not in our bed at midnight, we are not allowed to bill. So last year, fiscal year 2025, we lost $1.1 million by not being able to bill because the child was not in their bed at midnight.
Yeah.
So
Yeah.
that is a system change that we implore you to look at. Thank you.
Any further questions?
Oh.
Representative
Question,
Zager
sorry,
has a
I'm
question
sorry.
for you. That's all right.
Thank you, Mr. Chair. Thank you for being here. Look at the rest of your testimony for sure. The bill uses the verb stabilize.
Mm-hmm.
There's a lot that could mean. As a hypothetical, like how would you and your facilities,
Great
how would
question.
that like, what would that look like to you?
What would
And-
that look like? Well, as many people are going to probably tell you, it would give us the ability to pay staff, to recruit staff, to be able to continue to provide services. Honestly, if I'm just being honest, it would just pay the costs of running the program. I mean, our food has gone up. I mean, everyone here knows. No, I mean, we're trying to buy food for 8 children, and the food costs over the past years have just like quadrupled. Utilities, gas prices. I mean, just the basic needs. Our room and board rate has been cut in half over the last 5 years. So you would think each year we would be getting an increase in room and board rates. We've gone from, about $100 a day to $51 a day now. So it's been cut in half over the past few years. So to answer your question, the basic necessities of running a program, the food, the utilities, the house, the staffing, all of that. We have frozen all raises. We've frozen all administrative increases. And we just right now are currently only giving raises to direct care staff just to keep them with us.
And may I follow up? And these 2 facilities that are most vulnerable right now,
Mm-hmm.
$1 million would go, would they?
It would,
they
yeah,
get-
it
I mean,
would-
How
it
long
would-
would that last? And would they be the only ones that would be receiving that million? Like, what would that do for?
What would that
the people
do?
of, the families and the children?
Well,
that are in-
currently between the 2 programs are about $500,000 in debt. It would bring us to a point where we know we're going to end this fiscal year in debt. Last year, we ended about $1 million. We want to stay under $1 million in debt this year. So that would get us to, I mean, it's a really poor business model to say you want to stay under $1 million in debt, but that would at least allow us to survive if we could then be continuously working towards ways to, keep this funding going and keep we're in it for the kids. So it would help us pay some of our debt so that we could keep our doors open.
Okay, thank you.
Further questions?
Okay, thank you.
None. Further testimony in the room in support?
Good afternoon, Senator Ingersoll, Representative Meyer, and the distinguished members of the Health and Human Services Committee. My name is Justin Gifford. I'm the Executive Director of Beckett, Maine. I'm in strong support of LD 2125. A little background, March will be my 26th year with Beckett. We have had over the years several residential treatment programs here in the state of Maine. So pardon me if I meander a little. I'm trying not to be repetitive here, but over the past decade, my organization has been forced to close 33 children's residential beds across 3 facilities. 22 of those have been over the last 5 years, which are total 2 programs. One of them is the only program in the state of Maine that specializes in problematic sexual treatment for youths. That program works with youths typically between the ages of 14 and 19 years old. One of the other programs we shut down focused on youth from kind of 9 to 13. So that being said, routinely, I would say even in the last month and a half, I've had to deny 4 to 5 youth too young to attend our program, which is leaving them either boarded in a psychiatric hospital, an ED, or youth detention. And their best opportunity at this point, because they're not going to age into my population anytime soon enough, is going to be an out-of-state program, which, to be fair with that specialty, those are few and far between. They're more than likely going to languish somewhere and be frequent flyers in the EDs, potentially interact with corrections and things like that. These closures are not a result of poor management. They're really a direct result of reimbursement rates that no longer reflect the real cost of care, a severe workforce shortage, escalating acuity, and rising costs due to staff injuries, property destruction, accreditation, non-reimbursable bed hold days. For example, I got my rate letter. I was looking around through my paperwork today, and in 2004, the daily room and board rate for our PSB program was $116.43 daily in 2004. And 22 years later, our room and board rate for the same program is now $51.94 a day, which is, that's not weighted for inflation. And keeping in mind, inflation from 2004 to now is about 72%-ish, give or take. These costs, we can't withstand continuing to do a business model like this. And, it's a real challenge to keep the beds open. We are routinely denying youth that could be, looking at, 15 years ago, our full spectrum of care, we wouldn't deny half the kids and they would be able to get served here in Maine. Thank you for your consideration. Do you have any questions?
Any questions from the committee? Yes, Representative.
Thank you for being here. I have 2 questions. First, what's your break-even rate per day as of right now?
My break-even rate, that'd be a tough question.
Ballpark.
It would depend on the economy of scale. I've got an 8-bed program. I was down 1 youth and I had a lot of bed hold days in August. In the first quarter, I was down $9,000 running through the first quarter. And again, it really fluctuates around that. I think there are more rule changes that I think would push it in the right direction. But, I'm at least in an 8-bed program because really an economy of scale dictates it's easier to serve 14 kids than 8, given all of the fixed cost. I would say a program of that size, I'm at least $250 short on the rate, depending on bed holds and things like that. I think the real difference is looking at some of the regulatory pieces. I also have 2 unfunded positions, aftercare, which, in concept on paper worked really well. It was part of the Families First Act that kind of ushered in that we require aftercare up to 6 months following a discharge from our residential. Each of our children's residential programs has that position. It's a $40,000 plus year, closer to 50 now, because you have to have a bachelor's level person in a a $50,000 position doesn't account for the company cost. That's really closer to you add